Psychosocial history is the basis of primary care management. If a doctor has not done psychosocial history well, there is no way they can do primary care management. They will not. Why would I suggest occupational therapy, for instance, for a patient who have not asked if they are struggling with mobility? How would I ask for social prescribers for befriending service for a patient who have not asked whether they feel lonely at home? Okay. Good afternoon, everyone, and thank you for joining us in this series of teachings. This is the third one. On the first one, we did introduce ourselves to the SCA, and in the second one, we had a bit of a long lecture on structures of the SCA, and in the next three ones, we are going to be breaking down what we discussed last week. So I would advise those who haven't seen last week's one, please do well to see it, because it will help very significantly going forward. For those that are joining for the first time, my name is Olaoluwa Fajimi. I'm a GP and training program director in Coventry. Before that, I used to be a clinical tutor at Warwick University Medical School. So today we are going to be looking at focused history. Now, what are our learning objectives? Our learning objectives will be that one, that every doctor will live in here today knowing for certain what focused history is, because it's one of those phrases that are loosely thrown around and that are rather poorly understood, and that secondly, we all know what we've been doing wrong and we know exactly how to remedy that. So history itself is the process of gathering facts from the patient. It involves making the patient comfortable enough to realize that we want the same thing, and so they see themselves as equal partners. So it is balancing what the patient thinks is important with what we think is important. And as we all know in our clinical practice, we know these are not always the same. In fact, most of the times they are not. So it is the art of connecting, medical information and compacting them to very well established construct. So it's really the middle of the spectrum. We want the history being broad enough that nothing important is missed. And at the same time, it's narrow enough that we are not going on a fishing expedition. We are not asking what their grandmother had for breakfast, whether they've got family history of road traffic accidents or road traffic collision or not. Focused history is one that deals only with what is needed and necessary. We take it because we have limited time, as you all know. We have 10 minutes. We take focused history because we set the tone. Remember that a picture I showed you in the last teaching that had the patient part of the consultation, the doctor part of the consultation, and the shared part. So focused history is your own part of the consultation as a doctor. Another reason why we are keen on focused history is because our resources are limited, unlike in secondary care. And the fact that we see undifferentiated patients, anything and everything can walk through the door of your general practice surgery. It could be anything. So the doctor needs to be armed with skills to be able to narrow down exactly what's going on. And we all know that many times when patients come to us with a shopping list, they give us a lot of symptoms that usually mean more than one disease process. So without a focused history, we are going to struggle. It helps us to keep things simple. As far as this exam is concerned, it makes things easy for the examiner, easy for the examiners to follow. It helps us to identify exactly what the patient are concerned about. And it makes it easy for us as well to follow our own line of thought such that we do not miss anything important out. It protects our mental health. You don't need to finish 2-3 hours after your session closes because we are not taking a good history. And it's a key element of the SCA, and it affects every other domain. If a doctor has finished their history at 9 minutes, they are going to be quick. They will rush the patient, which will hurt all other domains of them. And it creates time. When well done, it creates time for you to manage well. It creates time for you to assess risk and manage those risks that you have assessed. And most importantly, and especially in the context of the SCA, it helps us to manage complexities. So why do we not take focused history? Many times we don't take it because we do not have knowledge of it or the skills needed to do it. And many times these tend to happen with very experienced doctors because you've been a doctor for more than 10-15 years. You know exactly how many things present. So within a few minutes, you already know what your diagnosis is. And this can stop you from taking a focused history. And many of us, we have learned bad habits over the time. And some have worked in all sorts of specialties, in hospital-based specialties, such that when we take history, we spend 40 minutes there, 30 minutes taking all the history. And some of us don't take it because we don't think it's important. And sometimes we want to take it, but the pressure of the exam, throws us off sometimes. Sometimes the pressure isn't from the exam, it's from the patient. And that's quite common in non-traditional cases where they've come for follow-up of their blood test and they're on your neck, doctor, am I dying? Doctor, this. And that sometimes can throw the doctor off. And the other reason why we may not take it is when we lose track of our own structure. We've got the structure right, but we haven't honed down the structure well enough that we lose track of it, and then things just go downhill from there. One of the things about a focused history is the concept of a doctor being a scientist first. Before you became a doctor, you were first a scientist. So you want the doctor to think just as a scientist would. You want that scientist mind to be there in terms of being inquisitive. The doctor wants to know exactly what is happening. So because the doctor wants to know what's happening, she's going to probe when she should, and when she should let go, she will let go. And second is that the scientist is unassuming. Anything that is not proved, the scientist does not assume it. There are no guesses. The scientist doesn't say anything unsubstantiated or anything that hasn't been established. The scientist has a fact-gathering mind. He just wants to gather facts, and he wants to use the facts he's gathered to be able to establish a working hypothesis, and based on all those, he wants to conjure a solution that will fit exactly what the patient has presented with, which may be completely different to what will fit another patient who has presented with exactly the same thing. So it is that personalized solution that the SCA is really looking for. Case priming. Case priming is you have your 3 minutes. What do you do with it? The questions that you are going to be given, they are going to be long questions. So that we will take about half a minute or a minute first. So scan through the question. Get down your structure. If you have not practiced your structure before and honed down on it well, don't start it on the exam day. It's not going to work. It's not going to work. So note down what your presenting complaint is. Note down other information that's been given, particularly the profession, the age, past medical history, and the medication that the patient is on. These four are some of the most important information that you're going to need to reflect on, to either gather more information, or you're going to need to bring in into your line of thought to support your establishment of hypothesis. Think of 3 to 4 differentials based on that presenting complaints you've had. For them, 3 to 4 symptoms of each of them. And your symptoms, ask them back to back and decisive. There is no stalling. It's not the time to go, okay, yeah, so you said no stalling. There are what we call nailing symptoms and not broad-based lines of questioning. For instance, if someone has come with an headache, the nailing symptom of that will be the headache being pulsatile. And when the headache comes, it means the end of the day for them and they having aura. If I were to ask photophobia, you can think of 2 or 3 other things that will come with photophobia. So it's not a nailing question in the context of my brain. So the examiners want to ask me mention 3 to 4 things back to back without hesitation, knowing exactly what I'm asking. If the examiner for any reason has any doubt in their mind, based on their clinical experience, that this is what I'm going to, or this is what I'm trying to exclude, it's not going to work. I'm thinking a patient has got COPD exacerbation. The most important thing I will be establishing is whether there is increasing shortness of breath or an increasing sputum production with it. If I do not establish that and I just ask them if they've been coughing, many things can cause cough. If they've been getting pains in their chest, for instance, many things can cause that. If they feel generally unwell, many things can cause that. So you're looking for the nailing symptom. Now, there is a concept of history taking, focus history taking as a risk management tool. When you're thinking as a scientist, one of the things you're thinking is, okay, what are the common things? If someone has come with cough, for instance, a viral upper respiratory tract infection or a lower respiratory tract infection is more likely than a pneumoconiosis or sarcoidosis. If someone has come with headache, for instance, a tension type headache is so if they are coming with an headache, for instance, a tension type headache is more likely than a short neuralgiform headache with conjunctival injection and tearing SUNCT. So when you've thought about the first things first, if it's not the common one, think of the second closest thing to it and think of the timing. If a patient comes and they're saying they've been having this headache for 9 months and it's getting worse, and I'm there excluding features of subarachnoid hemorrhage and features of meningitis, the examiners will know for sure that this doctor has no idea what he's doing. They will know for sure. So think of the time, of the duration of the symptoms, and use that to factor in your thought first. Someone has come with an acute cough, for instance, of 5 days. I will first be thinking of a viral cough and then a bacterial cough after. But if they've come with that and I'm excluding TB or I'm excluding sarcoidosis, it's not going to fly. Think of other things that are close and exclude those. Then think of the worst case scenario it can be, which is a possible complication of what you have established that is happening. And that will be your history of complication. Now, there are don'ts of focused history. And number one is that going into that exam without a plan or a structure, the history cannot be focused. Is asking questions just for asking sake without a direct line of thought of what am I trying to establish with this question. It's not going to happen. Don't just ask anything that comes to mind. If you feel stuck, summarize and carry on. Avoid stalling. Many of us are not actually stalling, but we are used to using certain phrases that depict stalling. Okay. Train yourself, practice to remove those stalling words from your vocabulary, because it's going to come across like this candidate doesn't know what they are doing. While you indeed know, we all know that there are people who just from habit or they're just used to it, use those phrases. And it's not necessarily because they do not know what they're doing. I don't know if you remember this three parts of the consultation photo I was talking about earlier. So now is that doctor's part. And by reassuring the patient that you have indeed understood their story, you will then be able to do your own part. Now, let's start from the beginning. Golden minutes. Allow the patient to talk. Don't interrupt them. Show interest. Let their emotion mirror yours. If they are anxious, let it mirror exactly what you're seeing them do. Be attentive. Use free verbal and non-verbal constructs that show attentiveness. If it's verbal. Right. I see. Okay. Non-verbal. Let your face lighten up when catchy things are said. Nod your head where as appropriate. This is the patient's part. Let the patient have it. Your part will come. This is the patient part. Let them have it. So when they are finished, if there is anything you need to clarify, if they've used any medical term, ask directly. Oh, you mentioned reflux. What do you mean by that? Ask directly and move on. Don't thank the patient more than once. Get a lot of people recording and, oh, thank you so much for telling me this. Thank you so much for this. That's their job. Don't assure them it's confidential. Oh, before we go on, I just want to assure you that this, they know it is. So many times they tell you two symptoms in the golden minutes. There is always a lead symptom, and there is something that is a subset of that. They may tell you, for instance, headache, and they may tell you, in addition to the headache, running nose, for instance. Headache is going to be the lead symptom. So deal with the headache first and foremost. Open-ended questions. Don't manufacture any emotions. Only react to what you see, what you've been told, and stay somewhere in the middle of that. Don't go, oh, I can imagine how horrible this headache has been for you, Josie. Oh, so sorry to learn about it. I can see you've been struggling at work, and all Josie has said is, Doctor, I've got a headache. Where is the imagination coming from? So only what you see and the emotion that's been expressed. Signpost, as we've described previously. Now the patient's time is over. That presenting complaint, do not continue with history until you completely exhaust that presenting complaint. When did it start? How did it start? Has it got worse? What makes it better? Only when relevant. Only when relevant. Don't ask a patient if what aggravated their road traffic collision, for instance. No. So only when relevant, we use that to completely exhaust that presenting complaint, starting with the lead one first, if we get to, and then bring the other one into it. The differentials, of course, will signpost as usual. True differentials. If they've explained headache, it's an acute headache. It's acute. It's been there 5 days, for instance. It's something they've never had before. I will not start my differentials by trying to exclude migraine. It may be migraine, yeah, but I will not start with it. I will start with more acute things first. If they've got cough, for instance, cough's been there for 4 days, I will not start by trying to exclude asthma in a 45-year-old gentleman. No. I will start from the upper respiratory tract infection, the lower respiratory tract infection first. And that's what that true differential means. Because this is what demonstrates to the examiners that this doctor is armed with all the skills they need to help them establish this diagnosis. They are not just manufacturing this diagnosis, they've worked their way through it carefully. As we mentioned before, your differentials back to back, no stalling, no use of okay, hand, hair, etc. No, nailing symptoms alone, and we'll move on. When some of us are doing this, many times when we don't get to our diagnosis, we then get anxious. Keep moving, trust the process. Even if you do not get the diagnosis, the fact that you have done the right thing means that you will get your full mark in the data gathering, and in the data gathering anyway. And in the diagnosis, if you then explain clearly your line of thought that, look, I'm not sure what's happening here, but from what I've gathered, it does sound like this headache is not anything sinister, you will get your full mark. You will score your full mark there. So many times we are that obsessed about getting that diagnosis that we do not even do the basics right. So focus on doing the basics right. Like I've told some of you that our path have crossed, that I prefer people getting stations they don't know at all than the stations they know. Because when people get stations they don't know, and they are well sorted with the basics, they will pass brilliantly well. They will pass well. So let's remove that obsession for the diagnosis. The diagnosis is a consequence of hard work. The diagnosis is a result. It is not the answer. The answer is the groundwork that has been laid. So if you're not getting to your diagnosis, be patient, trust yourself, trust the process, keep going. If you've excluded 3 or 4 close differentials, you still did not get your diagnosis, try 1 or 2 other differentials. If not, then go to your red flags. And if you've got your differentials early, and this is the one I fear about, because once you're excluding your differentials and you got your diagnosis early, that temptation to move on is there. Exclude 2 or 3 more things so that you can have your full mark in your data. Then the red flags, signpost as we've described previously. 1 or 2 is usually okay. Let them be real complications. Last week we did a case, I think it was on EP or EP. A differential of that will be cirrhosis. A differential of that will be hepatocellular cancer, as up to 18% of them can get HCC. So that will be a complication of that, rather, I apologize. That will be a complication. That's a true complication. So it is different from safety netting question, which we will discuss in our last teaching when we do shared management. 2 or 3 symptoms for each will usually be okay. Classical and nailing symptoms of it is what we want. Don't be over the place. Don't do a systemic review, except in one instance. If a patient comes with constitutional symptoms of an infective process, let's say they've got fever, they've got shakes, they've got everything, and you've tried your differentials, you haven't still nailed down what your diagnosis is, I would say something along the line of just to help me exclude where else this infection may be coming from. I will then start from head to toe. Have you got headache? Have you got cough? Have you got chest pain? Have you got tummy pain? Have you got bowel symptoms? Have you got urine problems at all? Have you got any swollen joints? Because I had narrowed it down that this is an infected process. I've excluded the differentials. I am still not certain. I will then do a quick systemic review to help me narrow it down to the system. That can happen. But when we are excluding red flags, for instance, someone has come with a pyelonephritis, the complication they will have, or they will have, if at all, will be sepsis. So it's those questions I will be asking. There will be sepsis, and if they haven't got classical symptoms of it, then I will be asking things like shivers, things like being very unwell, feeling very unwell. I will be asking those because those are the natural progression I would expect someone with pyelonephritis to have. Now, many times, many of us do well with the history. It is the transitioning from the body of the history to the remainder of the history we struggle with. And it just comes across as being weird and robotic sometimes. So there are linking words and statements and reflective statements we can use to transition seamlessly from the body of the history to, say, psychosocial history, for instance. Let's look at what this headache, what sort of trouble this headache is causing you. I mean, I recognize cough can cause troubles to loads of people in different ways. But in your own case, I wonder, has it been stopping you from sleeping? You have transitioned seamlessly. Don't go, now let's just look at the psychosocial history now. No. Let's have a bit of a chat about how this acne is affecting you. So that's how you will transition into the remainder of the history, and then only what is necessary. Psychosocial history is the basis of primary care management. If a doctor has not done psychosocial history well, there is no way they can do primary care management. They will not. If they do, they won't get the credit for it because they've not brought it out. How would I say that I'm going? How would I suggest occupational therapy, for instance, for a patient who have not asked if they are struggling with mobility? How would I ask for social prescribers for befriending service for a patient whom have not asked whether they feel lonely at home? So there is no primary care management without a psychosocial history. Reflect what you've been told. Ask generally first. Oh, how has it affected you at home? How has it affected you at work? Have you been able to? How do you think it's affected your quality of life generally? And then specific ones. If it's a joint problem, ask about mobility, ask about activities of daily living. If it's a pain-related or cough problem, ask about sleep. Let it be appropriate. Let's be creative with it. If someone has got diarrhea and they are getting 18 episodes of loose motion in a day, we can ask them how are they going shopping? How are they able to go out? How are they able to get things done at home? These are legitimate and appropriate questions. But we not fitting it into that patient is the biggest challenge we often face in here. For instance, if they are getting up all the time to pass urine at night, for instance, and they've told us it's nocturia, they are fine during the day. And I'm asking them how it's affecting their activities of daily living. The examiners are going to know that this doctor isn't creative, this doctor is not personalizing this patient, and they are not personalizing their care. And then we then take all the other history as necessary. As we've transitioned, we will also transition from there. Many times, this problem, it can run in families sometimes. Has anyone got anything similar in the family? And then broad facts and then specific, any history of cancer at all. So we transition from age to age. Social history, of course, we will signpost, just because many times our habits can impact our health in various ways. Then just build it up and ask, but don't make it weird. What I hear oftentimes is, do you by any chance? You don't smoke by any chance. You don't drink by any chance. You drink if you drink, you smoke if you smoke. It's cultural in here. It's common. So it's common, it's cultural. You either smoke or not. So don't let us denormalize it such that the patient feels like, oh, this doctor is coming across like smoking is not normal. And what the examiners are saying is that, oh, this doctor is judgmental. The doctor is not judgmental. The doctor is just coming from their own culture, where they feel like it is unlikely for you to see a 54-year-old gentleman smoking marijuana. And they are putting it into a new culture. That's what is happening. It's not that the doctor is judgmental. So in order to mitigate that, don't denormalize what's normal. For recreational drugs, ask younger patients as necessary. In older patient, if you want to ask recreational drug, yes, in those ones you can add an extra layer just because this can play a role. Not because we always ask. Because we always ask isn't a signpost. Ask about exercise. Ask about diet as relevant. Again, ask generally first. I mean, what's your diet like on a typical day? What do you have for breakfast? And then you can have an idea, and then on it. Don't ask too broadly. Again, family history only if relevant. Again, transition. There is a 6-minute rule of focused history, which has been recently widely acknowledged, especially in the context of the SCA. A doctor that has a plan will take a very solid history in 6 minutes. If it's significantly more than 6 minutes, it's very likely that the doctor doesn't have a plan. Very, very likely. Why is it important? It's important because the remaining 6 minutes, we need it to explore the complexity of management. We need it to manage primary care first. You will then need it to manage the medical problem itself. We are getting more and more complex cases, as you know, and also to manage the risks associated with those as well. So it takes a lot of time to do. And that's the reason why when the first part of it hasn't been done well, it's very unlikely that the second part will be done well. And again, patients are getting more knowledgeable with more access to medical information on Google, everywhere you turn. So patients are asking more questions. And it's the same way patients will ask you a few questions. When you're done, they will ask you. So create a little bit of allowance for that. And the only way to do that is to do your focus history in 6 minutes. So by the 7th minute, you are in your management already. So what are the top tips? Have a plan. There cannot be a focused history without a plan. Be specific, know exactly, or come across like you know exactly what you are trying to do at your own time. Don't slack. That is the key. Don't slack. Don't stall at your own time. Back to back, ask and move on. For those of us who we've had feedback that we use tall words, please practice, practice, and practice. Self role play. I will usually recommend sitting down in front of the mirror, giving yourself symptoms from head to toe. Start with headache, role play it, role play headache, role play cough, role play chest pain, role play it multiple times in a day. Talk to yourself, sit in front of the mirror, role play it, and then role play with colleagues as well. So the only chance in doing of doing a good job in 12 minutes is to do a focused history. That's the only chance. Without a focused history, a good job cannot be done. It's that foundation you will build on. I see a lot of people tell me, those examiners, I don't know, I did my management so well. Well, I did, because the management is an hospital doctor's management. Primary care management wasn't done. And it wasn't done because there was no focused history. As we all know, first impression matter. It also does in this exam. When it's your own turn after the golden minute and we are stalling, it doesn't create a good impression in the mind of the examiner. Thank you very much.